So I want to give credit to Dr. Neil Rouzier. About 25 years ago, I went to his course. It was probably a third of this size. He now does programs with WorldLink. You can get on Zoom programs. They train thousands of physicians on the use of these bioidentical hormones, and certainly was a pioneer in fighting the black box warning that, thank God, was removed last year, because it was always the conversation, why is my gynecologist, my orthopedic, or my surgeon, or everybody else telling me that I shouldn't take these hormones and that they cause cancer? And we all now know that that is not true. It's always been not true. And it was a sad state of affairs that women for the last 25 years were dying from osteoporosis, dementia, urogenital atrophy, and subsequent ural sepsis, et cetera, that this was all preventable. So, and most of you probably already know all of these things, but certainly premenopausally, a regular ovulating cycle, perimenopause, that transition, which can be 2 to 5 years prior to menopause. And then the classic diagnosis is 12 months with no cycles. Obviously, women need to be treated prior to all this because they can be in a pretty miserable state waiting 12 months with no cycles. Many women can enter menopause even at the age of 40. Not many, but a number of women can enter at that stage. The majority of women are going to be between the ages of 51 and 55, but they can be as young as 40. So that means those women would have been premenopausal in their 30s. So what are we dealing with? Certainly the hot flashes, which aren't going to kill a woman, but certainly are very miserable. And of course, our pharmaceutical colleagues have just recently come out with a drug for hot flashes. I rarely see any kind of rep that comes into the office, but this one came in, and I said to her, I said, well, what else does this do? Does it help urogenital atrophy? Does it restore bone density? What else does it do? She said, well, nothing. Just the hot flashes. I said, well, it can help sleep if you don't have the hot flashes. So most of my patients either are uninsured or very poor insurance. So I have to function in a way that I cannot order thousands of dollars of either lab testing or a program that they simply are not going to be able to afford. And I morally believe we should be able to have everyone at any level of finances have a right to be healthy. So I said to her, well, what's the cost cash? Because I have a lot of patients that are cash paying. She said, $500 a month. I said, well, the thing is, there is no woman that comes in my office that I can't get rid of hot flashes within a week or two and for a cost of pennies. So why would I even think about something like this? So it's the hot flashes, yes, the insomnia, and I'm glad my colleagues covered vaginal dryness and the treatment with estrogen, but certainly doing the full replacement of hormones, you are going to change up what's happening vaginally. Yes, some women at the beginning can need some vaginal treatment directly, but if a woman is started right from the beginning, we're going to prevent that vaginal atrophy. The weight gain, the average woman will gain about 20 pounds in menopause, and it's based on a number of factors. I mean, she's tired, she's not sleeping, she's not exercising the same, certainly eating habits can change, and then an increase in urinary infections, breast tenderness, all of this when estrogen's low. This is one of probably the number one reasons that we need to do hormone replacement for everyone. In fact, Dr. Rouzier's first books are written why everyone needs bioidentical hormone replacement. And that's the bottom line. Everyone needs to be doing this, and all physicians can do this. It protects the heart, it reduces heart failure, but this osteoporosis is 50% of all women. 50% of all women are going to develop this. And what we've done in the last 25 years is just given billions of dollars to the drug companies because of all the drug therapy. I have women that come in that have osteoporosis, and within a few years, they're back into osteopenia. Women who have osteopenia that are back to normal. I'm going to be 72. I have normal bone density. And every single woman, both my mother's side and my father's side, has osteoporosis. My grandmother, my father's mother, she died from the multiple hip fractures in that. And during COVID, my mother's sister hip fracture, and she was dead within 8 months. So it's all within my family. My mother lived to be almost 93 with normal bone density. She was on full replacement right up until the week she passed. And her death was caused she fell. She hit her head. She had bilateral intracranial bleeds, and that's a pretty hard injury to get through when you're almost 93 years old. So balance and all the other things that we can do that can keep women flexible, not falling, all of that's important. This is what I give my patients. It's a very simple circle of bone health. And if every woman from the time she started premenopause on was doing this, we would eliminate osteoporosis. And when you think about the major expense to our medical communities and to loss of work and to what happens in a family with this disease, it's terrible to think that something so cheap and easy could prevent such a dramatic and frequent disease. So these are the levels that I aim for in the blood. My patient population, the majority of them, they cannot pay for Dutch testing, saliva testing, all of these things that become so expensive. I can order all 4 core hormones for $71 through Life Extension. And I have to keep this in a way that people can afford it. And then obviously, most women, they could eat their calcium, proper dietary. Most patients above the age of 50 have intercellular magnesium deficiency, so they do need to take magnesium. If they have bone loss already, I tell them to do about 1,000. If they don't have any bone loss, they can probably get away with around 500. And I tell them to pick one that's going to be easy on their gut. So if they tend to be constipated, they can do magnesium citrate. If they have normal bowel movements, magnesium glycinate, and these things are over the counter. They just need to find a particular company, and I give them some recommendations of companies that have been good products. Vitamin D level needs to be in that upper quartile, and then enough on your minerals, your selenium, manganese, zinc, all of the trace minerals. I do use strontium as a mineral for my ladies who have osteoporosis. So I give them up to 950 on a dosing, making sure they're getting at least 1,000 on their calcium, and I don't have them mix the two together. They need to take the strontium at a different time than their calcium. And it seems to add to the bone building and restore back that bone density faster. So yes, 80% of women are going to have hot flashes. Proper estrogen dosing is going to eliminate this. And what do you need to be? On your blood, you need to be above 60. This is a very black and white, and there isn't anybody that couldn't do this. Certainly, avoiding alcohol, caffeine, tobacco use is also going to help to bring those hot flashes down. But 1.8 billion is lost annually due to women having hot flashes. Vaginal atrophy, and I won't spend a lot of time on this because you had a very good lecture all on it, but for my women that have vaginal atrophy, and I've seen some pretty severe cases, basically once you do the topical estrogen along with what I give them, either orally or transdermal by patch, cream, or dissolvable. So I have 4 different options that I can use with estrogen. How do I pick what I pick? Basically, you can do oral estrogen if you are a perfect candidate. No high blood pressure, no cigarette smoking, starting less than 10 years in menopause, and no genetics for clotting. Now, how do I pick out those people without running blood testing on genetics? I say to them, have you ever in your lifetime been on birth control pills? If they tell me, oh yeah, I was on them from 25 to 35, they do not have genetics for clotting because they would have had a blood clot on those birth control pills. So essentially, if you are a candidate for oral, I take oral estrogen. I've been the candidate. My mother, when I treated her, was not a candidate, and I gave her topical cream, which was the cheapest. So you can do oral estrogen for pennies. And why would I pick that for anybody, even if they're a good candidate, if I have other options that would always be safe? Because we do have data that has shown if you are a low-risk candidate, then it can inhibit plaque formation with aging. So at the age of 71, I have a 0 CT calcium score. And my brother has stents and a pacemaker, and he's 13 months younger than me. So the thing is, I'm sure is part of the whole program that has helped me to prevent any cardiac disease. And within my family, I have as many diseases as anybody else. From heart disease to cancer issues, you name it, it's all there. Sleep problems. Well, 40% of women ages 40 to 55 are going to have sleep issues. So one of the best sleep aids that a woman can be given is progesterone. So I'm glad my one colleague that was speaking, he sort of ended at this so I can pick up on it. Progesterone has been so much misinformation on it. First of all, it started off when the Women's Health Initiative study happened, and that ended in about 2002. By 2004, it was published in the Journal of American Medical Association that it was only Provera that caused cancer. Estrogen did not cause cancer. So this information has been there right from the beginning. But once the misinformation was put out, it just continued until last year the black box warning came off. So in treating menopausal women, my average dosing that women usually need is between 3 and 500 milligrams. And people are going, I've had pharmacists call me, oh, this is a way high dose, blah, blah, blah. Now, how do we know that that's the safe level that we can go to? We have a huge group, the women who've gone through in vitro fertilization. So for the last 50 years, we've used progesterone with in vitro. So when that embryo is transferred, that woman is placed. It used to be she would get an injection of 200 milligrams of progesterone. It could be 400, depending on what they needed to maintain that pregnancy. And that would continue in that first trimester of pregnancy. So we know that this is the greatest group of little test animals that we could ever have. Because anything you give in the first trimester of pregnancy, you're going to see the outcome right away. We saw that with thalidomide. Those kids were born without arms and legs, and those women were given that for nausea in the first trimester of pregnancy. So what do we know about those kids? Comparative to their age-matched population groups, those children have higher IQ testing, which is just amazing. So progesterone is so good for the developing fetal brain. It's also good for the menopausal brain. And you have to remember that in my age group, about 25% of women are starting to have memory loss and starting to have some cognitive issues. And over a woman's lifetime, 2/3 of women will develop cognitive issues, if not full-blown dementia. This is huge. So anything that we can do that's neuroprotective is important, and certainly all the other add-on modalities. And I say that hormones are your foundation. They're like your house. If you build a foundation and then you're doing all other kinds of things to the house, but the foundation is not good, well, you're still not going to have the best house. So if everybody would do this bioidentical hormone replacement and do the levels properly at the disease prevention levels, that everything else we're doing would simply raise the quality and the lifespan of our population, which certainly we don't have good statistics in this country at all. Testosterone therapy for women. Well, women can go down to 0 on testosterone. So I see many women coming in, their estrogen could be less than 5. It needs to be 60 to 100. Their progesterone is 0. We want to try to get that greater than 15. Progesterone is probably a little bit of a tricky scenario in that it's a large molecular size. And so you have to have a good gut to absorb what you swallow well. Topical creams, you're going to take a bath in it if you're going to do cream. So I don't do cream on progesterone. What gives the highest absorption? Dissolvables. So often I have women on combinations. Amount that's going to help them sleep and they're not tired in the morning, and then some dissolvable if I need to raise their blood level. And we like to see their blood level over 15. So testosterone, if that woman comes in, she's zero, she's obviously, she's not going to have libido. She's certainly not going to have the energy, the exercise capacity. She's going to start converting her muscle mass to fat mass. So testosterone is part of this whole picture. And many women don't need a whole lot. I mean, I take 10 milligrams 3 times a week, and my levels are in the 50th percentile for a younger woman. So basically, for most women, if you're doing it several times a week, it could certainly be enough. Most of my ladies are doing it by a cream. Cream's going to absorb well. But on my ladies that are older, I shouldn't say so older because I'm older now, but in their 70s or 80s, or I do have one lady, she's in her 90s. I'll give them oral and see how well they absorb it. If their blood levels are showing the free level to be between 2 and 4, they're absorbing. If they don't absorb well, then I'll try to switch them over to a dissolvable or a cream. But as a lot of women age, they would prefer something that's easier to take than just applying the cream. So what about our men? So basically, I do see a fair number of men. And essentially men, they're a little bit of a transition. I see sometimes men coming in that have been started on direct testosterone where they should have been tried with the precursors first. So if I have a younger man coming in that's in his 40s, his levels are low, I certainly look at where he stands. Has he got 100 pounds of weight to lose? What's going on? Is he a chronic daily pot smoker? I definitely see with the use of pot that there's a decline in their testosterone levels. And I will try DHEA, optimizing that between 3 and 600, again, blood testing, and HCG, human chorionic gonadotropin. So for many of these men, their levels will go right back up and we don't have to do direct testosterone. If I've tried them on that and they're of the age, especially once you get into the 50s. Most men in their 50s are potentially going to need that direct testosterone. I definitely follow them closely as regulated because it has to be entered into the E-force because it is regulated. And we know that certainly lower testosterone are associated with more aggressive prostate cancers. I run the PSAs regularly with their lab every 3 to 6 months, because Medicare right now is not paying for PSA testing above the age of 70. This is why President Biden had 10 years with no PSA testing, and when he was diagnosed with his prostate cancer, he was stage 4 prostate cancer. So I have patients go and pay $30 over at Life Extension because I need to know whether their PSA is normal or not. So essentially, if a man has low testosterone, it's definitely an impact on his cardiac status. We know that testosterone correction, they're going to raise their nitric oxide levels, which is going to increase their blood flow to their heart. It's going to lower their cholesterol. And there's no question it is a major thing for men in aging. A few years ago, probably 10 years ago, I was at a conference where one of the urologists spoke and said, if we gave 200 milligrams of testosterone weekly to the men in the nursing home, we would probably eliminate a lot of the lift chairs. So.
What do you consider low that requires supplementation?
Well, my aim is that for Quest Lab, that their free testosterone is between 90 and 155. LabCorp between 16 and 30, and that their total level is 600 to 1,000. That's our goal. So if I have somebody in their 40s, I'm going to do DHEA, optimize that between 3 and 600. And if occasionally that'll be enough, but if they need something more to try, then I'll start with HCG. If those two things by themselves do not get them to optimal levels, then I make that decision and placing them on the direct testosterone. Once you put them on direct testosterone, you're going to inhibit their own production. So you need to think carefully. If they're close to goal, I would not put them on direct testosterone to begin with. Or if it's a man that is still wanting to have children. So, I'll see somebody in their 40s and maybe their wife or partner is in their 30s and they're wanting to have children, then I don't want to start him with direct testosterone. And HCG is going to improve his sperm count and fertility. So, these are all things that have to be considered as you're managing. So we know there's an increase in the risk of heart disease, increase in risk of type 2 diabetes. Certainly men are going to lose their muscle mass, penile shrinkage, fragile bones, erectile function, memory loss. I had a patient once that was seeing a psychiatrist regularly, and he definitely needed DHEA and testosterone. DHEA is a natural antidepressant. Once his levels were optimal, he said, he said, if this had been done from the beginning, I wouldn't have needed the psychiatrist because he started to feel so much better. So evaluation with menopause is essentially 5 hormones. Estradiol, that needs to be between 60 and 100 on the blood. Progesterone needs to be greater than 15. Free and total testosterone at the 50th percentile of a younger woman. So you have to be careful because on the lab, they got my lab back at the age of 71 and my estradiol was less than 5. It will be called normal. And that's not normal. If my testosterone was 0, they'd call it normal. If my DHEA was 20, they'll call it normal. So the issue is normal is not optimal. And these are very straightforward black and white numbers. So this is why anybody can manage this. The DHEA sulfate, that should be between 150 and 400 on a woman with no teenage pimples. You have to remember DHEA is that causative scenario for acne in young kids. So if you see somebody that's got a lot of acne, and I've seen these kids, especially with PCOS, then they may have a level, could be 500 or 600 as a woman. So they're pumping out that DHEA, and that's what their issues with their acne. So if somebody has had that history young and now I'm seeing them in menopause, they're going to be a lot more sensitive to the DHEA. So I'm going to start them low and go slow and see how their skin handles it all. Thyroid, you had a good lecture in regard to the thyroid. So basically, it is optimizing these numbers. And there they are. This is what I aim for with thyroid, is that the TSH is less than 2, especially if they're positive on thyroid antibodies. They're free T4 and free T3 in the upper quartile of the lab. So doesn't mean I start them all on direct T3 and T4, because certainly I want to make sure their vitamin D level is good, they're getting enough trace minerals, they're getting enough iodine, all of those kind of things. And that was covered very well earlier. How do I monitor? Pretty straightforward. I see the patient, then I get lab 4 to 6 weeks later. I have them come back. If I've hit goal, and occasionally that does happen, that I'll hit goal with everything, then I won't see them again for maybe 6 or 8, 10 months, depending. If somebody still needs an adjustment, then I'll repeat the lab again 4 to 6 weeks later. If they're in premenopause, well, it's going to depend. I look at what their hormone levels are. Before full menopause starts, often their DHEA is going down, their testosterone is going down. And so then I work on correcting those things because the estrogen is the last thing to go. Monitoring for the men, this is every 3 to 6 months. Their CBC, their chemistry, their free and total testosterone, their DHEA sulfate. And again, the treatment with men, I'll often try with the younger men, the human chorionic gonadotropin, the DHEA. I am not a fan of pellets. So what I have seen with pellets, especially for women, I've seen levels of testosterone 4, 5, 6, 700. They come into me, they have cystic acne, clitoromegaly, they're losing their hair, they're getting facial hair, and they're all over the board. So, and I had one lady tell me, I felt like I was literally becoming psychotic because her levels were completely not physiologic. As a menopausal woman, you want stability and peace. You don't want to be all over the board. So we need stable disease prevention levels, easily monitored by blood testing. And that's how you're going to feel the best. And that's how you're going to prevent these major diseases. The men, again, every 3 to 6 months. Obviously, I let them know that it's not me being a bad guy seeing them that often, that I have to do it because that's the law. Category C3, be entered into the E-Force. And all this regulation, of course, came from the bodybuilders in the gym use. It's still happening. Too high, and this is our bodybuilders, of course. The acne, the hair loss, irritability, aggression, certainly it affects cardiovascular issues, blood clots, headaches, all of this. So hormone replacement therapy is a life-saving and quality of life, and everybody needs to do it. It's not that hard. It really isn't that hard. I mean, it's just a matter of re-educating yourself about how to make a judgment with each patient, which is the safe route to give, and essentially following the lab. So I do make sure their exams are up to date. I can't tell you how many people I see that really haven't had a physical in years. And then it's an individual management for sure. So that's what we've got.